Welcome tonight to our Mpumalanga branch. Good evening to all our viewers and all our colleagues. Welcome to the Mpumalanga branch webinar with Dr. Idah Mmutlana. And just a few house rules before we start. Firstly, please refrain from using the raised hand, but type your comments and questions in the question and answer tab. CPD certificates will be loaded to the SADA platform, and you will be able to access all your certificates under your profile or your member profile. If you're not a SADA member, you will be able to create a profile for yourself and access your CPD certificates. The event for tonight qualifies for 1 clinical CEU. We're also streaming live on YouTube, just in case you have difficulty to access the Zoom platform. Please, you're reminded to complete the evaluation after the webinar. That will be nice for you guys to just evaluate the speaker and so forth. And I just want to inform you guys of upcoming webinars. Firstly, SADA is holding a dental and oral health virtual congress from the 27th to the 29th of August. And the theme is Back to Basics, Excellence in Dentistry. And you guys are welcome to register on the Congress website. It's www.sadacongress.co.za. We're also having a webinar on the 29th of July. That's in 2 days. And the theme is orthodontics, only about straight teeth, and that's Dr. Idah Mmutlana. And then next week, Tuesday, the 3rd of August, there's another webinar held by the Northern Cape, a branch of SADA, and the theme is Clinic to Lab Communication, Basics of Doing a Smile Makeover. And the speakers are Mr. Bram Wall and Dr. Wim de Beer. Tonight, I just want to welcome our speaker tonight. And the speaker tonight is Dr. Mmutlana. And I just want to quickly introduce her to you guys. Dr. Mmutlana completed her BChD degree at the University of Western Cape in 2001. She did a community service in Ellisras, Limpopo, and she joined the Medical University of South Africa, MEDUNSA, in 2003, where she commenced the academic career. She obtained a Master's of Dental Science in Oral Microbiology in 2010, where her special interest was oral manifestations in pediatric HIV patients. She then joined the University of Witwatersrand in 2012 to pursue her Dent in Prosthodontics and qualified as a Specialist Prosthodontist in 2017. She worked as a full-time dental specialist and lecturer in the Department of Prosthodontics at Wits University from 2018 till January 2021. She recently joined the Department of Prosthodontics at the University of Pretoria in February this year. She also enjoyed membership in International College of Prosthodontists, DPA, and is an alumni member in Future Leadership in Prosthodontics. She has presented at both local and internationally. Dr. Mmutlana, we welcome you tonight, and we're very excited to hear your theme, tooth preparations in fixed prosthodontics. Please enjoy the lecture, and over to Dr. Mmutlana.
Good evening, everyone. Can I just get an indication if you can see my slides?
You're 100%, Doctor.
Okay, thank you so much. Thank you so much to SADA, Mpumalanga branch and the head office for hosting me. It's been quite an honor. I must make a disclaimer that I am overdue to rejoin SADA. I was a SADA member many years ago, but there's been a lot that's been happening, so I think it's only a matter of time I should come back to SADA, but I'm very much honored to be given this space to share. And as the title explains, my topic is about tooth preparations in fixed prosthodontics. So over the years, from the time that I was a registrar right up to the time that I've been teaching as a specialist, I got to perceive that there's a lot of changes that have taken place, and sometimes patients who were treated in the private sector in various places come back into the clinic with debonded restorations or restorations that have failed. And when you look at the preparation geometry, you have a lot of questions about the knowledge. So basically, this is, it's a combination of a refresher of where we come from and also where we are going and what are the anticipated changes that you might find happening. For some of my vet students who might be part of this Idah Mmutlana webinar, you might find that this was more like a refresher course because there is some of the core principles that I've included, but also at the same time it would be exciting to see what technology is bringing and what changes are there. So basically we all know that the reason why we have to prepare teeth is because teeth often go through substance loss due to caries, due to trauma, or due to wear, and then therefore we have to make a decision when we do treatment planning whether we're going to restore them with direct or indirect restorations. And essentially the reason why we prepare the teeth is to accommodate the restorative material. From this perspective, you will realize that this is the one mechanical aspect that throughout many, many years was driving the fundamental principles of tooth preparation. We were not looking at it anything else except take away decay, have some tooth structure that can accommodate the material. So that was fundamentally it. I want to take you through a very interesting journey, which is historical. If you look at around about the 1747, there was Pierre Fauchard, a clinician, who actually used to take crowns, and he wanted to bond crowns to teeth, and what he would do is he had crowns that had two roots of anterior maxillary teeth, and he was using mastic. So if you don't know what mastic is, it's more like the gooey stuff that comes out of a tree trunk, and when it's heated, it becomes more like adhesive. Am I still audible? I think I got disconnected for a while.
Hi, Doc, you are audible, but if you could maybe check your Wi-Fi or your network, it seems it's a bit low, and that's what's causing the break in sound.
Okay, I apologize for that. My internet has been, it started to act up and it was fine all along. So yeah, let me just quickly go back to my screen again. Okay, can you see my screen and hear me?
Yes, Doc.
Okay, great. So essentially what happened was this Idah Mmutlana, and it's a very interesting concept. He used to have a pivot or a post made out of wood or metal, and he would have the crown also that would be made out of very interesting materials, wood, ivory, animal teeth, sound human teeth, and he would have them as a single unit, and he would screw in this pivot into the canals, and he used all sorts of other retentive things like threads. So it basically looked like a nail with threads, or it would have spring designs of pins and retention. So you can imagine how traumatizing it must have been to be a patient sitting in the chair and you're having this pivot being screwed into your tooth canal. And then later on, he came up with the first porcelain pivot crown. So now we were making progress. We had a porcelain crown for a change. It wasn't human teeth or animal teeth anymore. However, if you look at how he prepared the teeth, he was using very aggressive types of instruments. He was using saw blades and excision forceps and files just to be able to cut a tooth preparation for the crown. And then the pivot space was being prepared with broaches and burrs and spiral drills. So I can imagine you're sitting there and the dentist is sitting with saw blades and cutting your tooth structure away just so that they can accommodate that crown. But it is this guy here, Charles Henry Land, who was the real paradigm shift changer. You know, he's the guy that brought the change, who for the first time said, it's not about mechanics, but tooth structure. We also need to do procedures that are less traumatic, that cause less fracture, and that are not fatigue inducing to the dentist. So I'm sure if you spend the whole day with saw blades cutting tooth structure, it must have been a very tedious exercise for the clinician and for the patient as well. So Henry Land was the one who really became the person that brought the paradigm shift. And then it was based on these things that for the first time, the considerations started affecting every other aspect, biologically, mechanically, aesthetically, and even psychologically for the patient, that these things were being considered. So we had a big change from just focusing on the fact that only cutting away tooth structure and replacing it with material was there. Now the objectives started changing. We started wanting to achieve better aesthetics, and hence we had brought the porcelain crown. We wanted to prolong the life of the restoration. We started talking about preserving remaining tooth structure. We started being concerned about pulp vitality and maintaining occlusion and periodontal health. And actually, the person who summed it up so beautifully was Schillingberg in 1996, when he laid out all these concepts: preservation of tooth structure, retention and resistance, structural durability, marginal integrity, and preservation.
Hi, sorry, Dr. Mmutlana. Sorry to disturb you. We've lost your sound. We cannot hear you from our end. Perhaps if you would like to rejoin and then maybe reboot your network as well. We completely cannot hear you. Thank you.
All right, am I audible now?
Hi, Doc. Yes, I can hear you. It's just the network that seems unstable.
Yeah, I'm in Pretoria Eastern. We've been struggling a lot with power, so I'm thinking it might have affected channel. But am I better now?
I can hear you. Yeah.
Okay. So let me go back to where I was on this slide. I was talking about the fact that when you're preparing the tooth, you need to consider the fact that the tooth has already been subject to some level of insult, the caries or the trauma or the way, and there's bacterial activity in the mouth where this tooth is located. There are rotary instruments that are being used on the tooth structure where there's actually heat also being generated at the same time. And thankfully, over the years, it's been learned that if we apply water sprays, and actually not just water sprays, but those that are there is there, but it's not really directed to the tooth, most of the time to the patient's face. So with the development of better handpieces that can actually direct the water in the right direction, we can also induce less insult to the tooth structure. Also to consider the rotational speeds. High rotational speeds are actually preferred. When I was doing my MDent research report, I actually had to look into what happens at histological level, and it was found that as soon as you take away 500 microns, and that's 500 microns of dentine, already the odontoblasts start to react. You start to see a lot of activity, and it's almost like they show that they're being subjected to trauma. So it's very important that we consider how much remaining dentine thickness we are keeping there. And we've gone from 0.5 to 1 millimeter to 2 millimeters, but essentially what is important is how far are you from the pulp and how much of that dentine can actually protect it. There's also other things that we subject these teeth to, pressure. For example, when you're taking an impression, this PVS is a very resistant material, or your impregam, so the pressure that you apply on the tooth, you're already applying to a tooth where there's no enamel, or the enamel is only located at the margin, and you've got a core that's made out of dentine. So the pressure that you subject to those dentinal tubules as well, those are some of the things you need to consider. The chemical insults that come from the impression materials as well, and sometimes even when we are expected to be etching some of these tooth preparations of ours. So in treatment planning, the most important thing to remember is preserve what remains rather than trying to meticulously replace that which is missing, and minimize how much you're reducing, and of course putting that in line with how much tooth material requirements are there. For example, if you're going to use gold, it will probably be a little bit thinner than if you're going to be preparing for feldspathic porcelains. So you would try to align those two. And wherever possible, if you can opt for a partial coverage, if you can rather put an inlay or an onlay instead of a full restoration, that would be the best thing probably to take, because you're reducing less tooth structure. So in summary, we need to be looking at, when we are delivering a restoration, the patients will often be very much concerned about functional aesthetics. For them, it's a clear-cut line, but for us, it's a lot. For us to give back that which they expect, when it comes to aesthetics, it's the choice of material, it's the shade selection, and also it's the design of the restoration. And thankfully now, we have not just moved from one classical shade guide, but now we've got 3D shade guides, and we even have spectrophotometers that make us react it more accurately. And mechanically, as I had highlighted some of those things when I spoke about the concepts that Schillingberg raised, and also to be concerned more about the biological aspects, the vitality, the health of the periodontium, and occlusal harmony, of which most of the time the patients may not be able to tell you of the first two because they're anesthetized. It is up to us. We have that ethical and moral obligation to make sure that we maintain that. So moving on to the second point, I want to talk about resistance and retention. First of all, let's think about how many forces and which types are being teeth are being subjected to. If you look at the box A, the tensile stresses we're talking about. Before we do that, I want to not put the audio. Let's do that. Okay, sorry about that, but we are back. The internet is not playing very friendly today, but yeah. As we progress, these are the various components of forces and also your compressive forces that go onto the occlusal surface of the tooth. So, zooming in a little bit on that, if you're looking at retention and resistance form, we basically talking with the retention, we're looking at the forces that dislodge this crown along the path of insertion or along the long axis of the tooth itself. And if we're looking at resistance, sorry, my picture's a little fuzzy there. We're looking at forces that want to dislodge this crown in any other direction other than the occlusal. So we're talking about masticatory forces. If you think about every direction that the jaw moves in when the patient is chewing, it's not just going to be horizontal or vertical forces that we are concerned about, but also axial forces, oblique ones and lateral ones and horizontal ones. So that basically in a nutshell, your retention form, you hope to combat the tensile stresses, and your resistance form, you hope to combat the shearing forces or the shear forces that are more horizontal. So your preparation geometry, ideally, where we come from or where we are now, is that we've been talking about preparation geometry being the one that makes the retention form to be achieved much more than cementation. And that way, then you actually making the cementation to be an additional type of retentive element. And we will achieve that if we have only one path of insertion. So if you look at the diagram that I've put on the side here, if you've got a cemented restoration, what will happen is the cement itself, if your preparation it has got a retentive form, the cement itself will stop the two surfaces from sliding against each other. So basically the restoration against the tooth, as you see on A. However, if you have not allowed and you've over tapered the restoration, any other force that comes in any other direction is not going to stop this crown from being lifted off the restoration. So that is something that is super important to remember. Incidentally, there was a study that was done by Charles Goodacre, I think it's in 2001. And he took all the clinical restorations that were prepared by undergraduates during their techniques course, and after their like when they were doing during the techniques course, when they were being tested during their test case, and also after, and then when they were in the clinical process, and then he also took restorations that were prepared by clinicians in private practice. It just so turned out that actually the private practitioners had been the one that had over tapered. And my concept of that was the fact that it's probably because the students were more concerned about being evaluated and passing the course. But once they had gone past that, there was nothing really that stopped them from over tapering to whatever degree. So if we think about a path of insertion, it's like an imaginary single line along which you can seat that restoration. And we need to determine which direction is there, just like partial dentures. Which direction is this restoration going to be seated in? So one of the things that we can do is we can increase the axial walls. We've got a longer surface area for bonding to cement. There's a longer route for when tensile stresses are actually being impacted on the tooth. But also if you look at the resistance part, where we're trying to avoid forces that are directed in an axial direction, I mean in a non-axial direction, but rather in a lateral or an oblique direction. If your crown preparation is too short, then certainly the dislodging forces will act like they do on C. The horizontal forces and the oblique forces will just come and debond. However, if they find there's a longer axial wall, then that's what would help. And ideally, we should be having about 4 millimeters posteriorly on any restoration and 6 millimeters anteriorly. So these are just the fundamental basics, really. The other thing that we need to look at is back in the day, it was a good thing to have parallelism. Probably the old school clinicians will tell you that if you had that flat-ended burr and you did a shoulder margin and you had parallel walls, you get maximum retention. But what we found is that that creates a lot of undercuts. And because of that, we end up having a lot of problems with when the restoration has to be removed. So taper or angle of convergence is actually what we're talking right now. There's been many concepts surrounding this issue of taper. They were saying you must have 3 degrees of taper on either walls, and therefore when they converge, and I'm going to explain what this angle of convergence is, that it should make 6 degrees. But clinically, that is not achievable. It needs to be something that can be measured and can actually be achievable. So right now, when we speak about the convergence angle, we're talking about if you take 2 lines, you put one on the buccal or the lingual wall of your tooth crack or the mesial or the distal wall, and you extend these lines all the way up to where they connect. The angle that is formed between the 2 of them is what we call the angle of convergence. And this angle of convergence is actually, there's been many arguments about how far this angle of convergence can go. Like I said, historically, it was believed it has to be 6 degrees. And then if you look at the study that was done by Aida, the study that I was speaking about, were comparing preparation dimension, who had tapered how much. Incidentally, the patients were tapering between 10 and 25 degrees.
To all the viewers, we really apologize for this bad sound and the interruption in connectivity. We're working on that. Thank you very much.
All right, I'm just going to try and get, am I audible?
Yes, you are.
Okay. Sorry, I'm really struggling with the internet today. I'm not particularly sure what's happening. I really, truly do apologize for that. All right. So, as I had mentioned before, if you excessively taper the preparation, then you've got too many parts of insertion. You probably would even struggle to insert the crown, and at the same time, you are most likely going to lose your retention and resistance with time. And you will be totally dependent on cement. There are other elements of auxiliary retention that have been recommended before, and this works very well for our porcelain to metal crowns, where you add your proximal boxes and grooves, of course. So in summary, you want to achieve your retention and resistance by making sure you've got a single path of insertion. You've got a taper or an angle of convergence. You've got an adequate length of the preparation. I also didn't mention in the diagrams, but also the diameter, because if you've got a narrow diameter, again, your resistance is going to be reduced. And also your auxiliary retentive elements, if you are able to implement them in the type of restoration that you are going to be making. Then, in addition to that, the cement will then be helping to improve the retention. With structural durability, as you know, you have to have adequate occlusal reduction. And in the midst of all of that as well, you've got to incorporate your functional cusp bevel, which is that bevel that is at 45 degrees and is about 2 millimeters wide, and it runs between So in a nutshell, you want to have margins that are located in enamel that are supragingival if possible, because for the dentist, they're easier to see even when you're taking your impression. And also for the clinic, for the patient, it's easier for them to maintain the oral hygiene and periodontal health. You want your margins to be smooth. They must accommodate the bulk of material so that they can withstand the crews of forces. And ideally, they must be into structure. I know we have new concepts such as the deep, I think they call it deep elevation or something like that of the margin. That concept I personally do not ascribe to, because I feel that if you are going to be seating a ceramic restoration or a metal restoration on top of a resin which is potentially going to undergo polymerization, it's only a matter of time before your marginal integrity fails. So ideally, your entire margin can be to structure. Your core can be built up by some material, but the margin itself should be into structure, should be tight fitting. We will never really have 100% zero micro gaps, but I know that we need to try and minimize the marginal gap between our restoration and the tooth structure, and minimize how much of cement has been exposed, meaning no marginal gap at the time. So other guidelines, it must be identifiable on the impression. And lately we also use CAD/CAM, so we're talking optical impressions too. If the impression has been poured and the model has been cast, you must be able to see your margin on the cast. And it must conserve the tooth structure, and most importantly, it must not violate the biological width. I want to quickly take a run through the historical margins that we have had. The knife edge, the shoulder margin, the shoulder with the bevel, the sloping shoulder, the chamfer, and the deep chamfer. I want to do a quick run through the first four. Sorry about that. The knife edge was initially utilized for restorations that were metal, full metal, like your gold. The challenge with this metal, as you can obviously see, if you're going to be trying to use it on something like porcelain, you don't have enough thickness of material and they would fracture. And taking an impression and trying to find a margin, or casting a model and trying to find the knife edge margin, is quite a challenge. So personally, I wouldn't prefer it, and currently it's not being used. Your shoulder bevel, the beautiful preparation, was used for many, many years. It allowed for bulk, especially for porcelain restorations. It was used for bulk. You needed the porcelain to be bulky enough, so you had a perfect shoulder margin, 90-degree angle between the restoration and the surface of the tooth, but as I had mentioned before, undercut. Then you had a shoulder with a bevel, which was used now for the metal restorations again later on. So
to all the viewers, to all our colleagues, we're really struggling to get 100% connectivity. We're working hard. Okay, there she's back again. Dr. Mmutlana, can you hear us?
I can hear you loud and clear.
Okay, thank you, Dr. Mmutlana.
Continue. Okay, so now we were talking about the sloping shoulder. The problem with it is that the angulation of it actually creates a weak point, particularly if you're using porcelain. So it's also not one of those margins that are preferred. The two margins that are actually really focus on are the last two, which is your chamfer and your deep chamfer. So the chamfer As you can see, even the choice of bird that is on there, it provides nice rounded axial-gingival lines, and it creates this obtuse angle externally between your axial wall and your gingival margin towards the soft tissues. It's a clearly identifiable, distinct margin. It's got nice internal rounded line angles, which are favorable for how stress is distributed. It's easier to prepare, and it allows for adequate bulk of material. So it's one of those margins that we choose that are very good for your porcelain fused to metal restorations, which were introduced a long time ago, but are still very much in use. The only thing you need to Okay, so we are back. And as I had mentioned, the margin is also allowing for adequate bulk, and the beauty of it is that you do not have HA lip. So these ones are very good for your all ceramic restorations. So if you have any flat-ended burrs that you are using right now for crown and bridge, I would say take them, take them away, and rather look for burrs that have got a rounded line, because they will provide that good deep chamfer for you, which is very favorable for shear stresses as well. So in a nutshell, what am I saying? The recommendations from the studies are that the first four, do not use them at all. Rather opt for your chamfer with your porcelain fused to metal restoration, or for your deep chamfer if you're going to do any materials that are all ceramic or porcelain fused to metal as well. Right, so my summary of your margins are that you should not violate the biological width. I will not get too much into depth about the biological width, but if you think about your junctional epithelium, we should not go anywhere close to it, and we should try to stay clear of the DEJ. And then, as far as we can, avoid subgingival margins. Sometimes we cannot help it. The caries extend subgingivally, the fracture line extends subgingivally, but wherever possible, we should try and locate them more supragingivally in the posterior region, and perhaps equigingivally, or at least 0.5 millimeters above the gingival margin when we are in the aesthetic zone. A study by Okin and Reddy actually showed that subgingival margins tend to cause more bleeding and recession. So wherever possible, again, I would emphasize, go supragingivally or equigingivally. Also, Jalalian et al. In 2011 showed that chamfer margins actually offer greater fracture resistance when opposed with shoulder margins. The shoulder margins tend to concentrate the forces more and push them back into the porcelain, and then the porcelain fractures. But now we have had some disruptive technologies that have been taking place in the world of dentistry. The industry is developing very fast, both on the direct and the indirect restorations. And these things, as I had mentioned before, the principles of tooth preparation historically were driven by the materials, the restorative materials that were there. Now, more materials are coming in. Actually, it is more the direct restorations now that have got more polymers that are stronger, that can be milled in blocks, that can be turned into partial coverage restorations. And we also have a change in the ceramic materials. We're not just stuck with feldspathic porcelain. And there's a big change that's been happening in the ceramic world. So all of these things, the advent of disruptive technologies like CAD/CAM, and the development of adhesive cement. Back in the day, we only had chemical cements that depended on micromechanical bond. Now we've got those that actually actively adhere to tooth structure and to porcelain, and the evolution of bonding systems as well. all of these things are paradigm shifters that are now making us to rethink the way that we are preparing our teeth. So my question is, do preparation designs, because right now, the buzzword out there is minimally invasive treatment options. From now on, when we talk about rehabilitations or full mouth rehabilitations or talking about aesthetic restorations, and right now there's a high demand for aesthetic restorations. We've got Dr. Google and every patient out there who sees a celebrity with A1 shade, white teeth, they all come in and say, I want to whiten my teeth and I want to put crowns from molar to molar. So are you still going to use the same principles that you used before that you learned in undergrad to prepare for the newer materials that are here, to prepare for the CAD/CAM technology that is here? And the reality is that we have to change the way we think and the way that we do things. So I'm going to look at the influence of the restorative materials on evolution of preparation. If you look at our metal restorations, for example, they were mainly full gold restorations used for posterior teeth. Of course, in some of our communities, they also go on anterior teeth as part of aesthetics. We've got L-shaped and U-shaped gold veneers, but they were good restorations, and the gold crown is actually still considered a gold standard if you're talking strength, if you're talking superior quality. But, and the beauty of it is it could be burnished and so you could seal the margins properly. The preparation design was also very minimal. It was about 0.5 to 1. So if you really look at it, it was a minimally invasive technology. We're not starting to do retainers for a Maryland bridge. They were also minimal or no preparation, although there was some debonding and techniques had to change where instead of using 2 retainers, now we had to use 1 retainer. So that this minimally invasive technique, it's not a new concept altogether. It's just that we have more materials that are more enabling now. And other things, as I had mentioned, that can change. So based on that, now we are able to do partial coverage restoration. For example, you could do a 0.7 millimeter marginal reduction and a 0.5 millimeter reduction of functional cast bevel for the gold. So if you really look at it, it is minimally invasive. It's not a new concept. But the limitation, as I had said, is poor aesthetics. So for some anterior restorations, it really was not a good idea to use it, except that the patient demands it, as a fashion statement or for whatever reason. And then porcelain veneering to metal also was introduced to try and overcome those aesthetic limitations. And now, because we were veneering porcelain on top of a metal substructure, it meant the 7 millimeter to 1.2 millimeters so that we can have 0.8 for the metal substructure and the additional 0.7 to put the porcelain on top. So now we were no longer talking about preservation of tooth structure. Let's move now away from the restorations with a metal substructure and move a little bit towards the ceramic restorations. Originally, we had the feldspathic porcelain, and I'm going to show you more or less what the structure looks like so that you have an idea. They were highly, highly aesthetic. Oh my God. Okay. They were highly aesthetic. They had poor strength and poor fracture resistance. So they needed more bulk. They required wider aggressive preparations. And I mean, a margin had to be 1.5 to 2 millimeters in order to be prepped, where you're on top of that, you still had to, again, prepare occlusally for 2 millimeters. So they had a high risk for pulpal exposure. Patients had beautiful crowns, which later became sensitive, and eventually they failed. So essentially, this is what I wanted you to look at, what the changes that have taken place with our ceramics. So if you consider the fact that this is the feldspathic porcelains, they were predominantly glass, and I want you to get out of the dental world a little bit and think about glass itself, that it is very transparent. If you had to put light through this glass, they had tiny little particle fillers within this feldspathic porcelain, just obviously because it's not, so that it's not transparent, but it's a little bit white, and it mimics tooth structure. And with the predominantly glass, if you think about it, if light had to pass through this structure, it can actually glow and give that translucency and therefore superior aesthetics. And this is predominantly where the feldspathic porcelains were. But if you think about it as well, if you had to have a fracture running from one end of this glass to the other side, it would just transverse through very quickly because there aren't many fillers to stop the propagation of the fracture. Now, Right here in the middle, this is exactly where the change has been for the past couple of years. This is where the science and the art of ceramics has been at play. And it was about playing around with particle fillers, or with the particles that are going to fill the glass to try and make it more stronger. And now this is where the current ceramics or the CAD/CAM ceramics are being placed, and even some of the previous ones like your alumina. And then zirconia is one of those that are polycrystalline. So same way, if I use the same analogy again, if you think about light passing through, the particle fillers would probably still refract the light ray. However, at the same time, the light would still be able to somewhat be transmitted through to the other side, portraying a superior optical appearance and aesthetics. At the same time, if you had to propagate a fracture, probably it would take a while, but it would manage to get through to the other side. Now, if you look at the polycrystalline structure, if you had to try and get the same thing happening through the polycrystalline structure, this is a very compact structure, and this is more or less what zirconia is like right now. That fracture propagation, there can be fractures, however, for them to be propagated through this polycrystalline structure, it becomes quite difficult, and that's where they draw their being opaque because they're not reflecting the light through, and at the same time, they are super strong. So this is where the zirconias are. And this is basically what I was trying to display, that if you look at the particle fillers, right here is where we've been at play, trying to find out the different types of filler particles like lithium disilicate and alumina that could actually make the originally glass content to be more strong. And then if you look at the high glass content, that's where your feldspathic porcelains are, where they were very, very translucent and yet not strong enough. But if you look at your polycrystalline structures like your alumina and your zirconia, that's where we are. However, things have also transcended quite a lot on the indirect restoration side. Now we've had a mixture of polycrystalline ceramics, not only that, but they now have an incorporation of resin matrices. So those resins not only, because one of the things about zirconia, especially if you're using it as a framework, it is very rigid. So now they become a little bit more flexible, and the flexibility is a little bit more compatible to the flexibility of tooth material. So then they become also better materials or superior materials to use. This is the classification that Grace's put up in 2015 after the one that I previously showed you by Robert Kelly, to try and show you more or less what the developments are. And it is in these resin matrix ceramics and the nano ceramics that right now we are having competitive materials that can provide a lot of aesthetic as well as strong restorations. So what are these newer ceramics and ceramic-like materials able to give us? They properties are far superior to feldspathic and disilicate. Now they can be used as a monolithic crown. And what I essentially mean is you take the material as is and you fabricate a crown from it. And then as a coating, and you require to veneer the porcelain, now there comes the problem. Porcelain, as I had said, historically, it requires bulk. So what does that mean? You cannot have that type of restoration without having an aggressive preparation. However, if you're going to mill it as a monolithic crown, you can still get away with having a preparation that is less aggressive. So while we taught you in undergraduate that for a monolithic zirconia crown or for a monolithic Emax crown, you can have a preparation margin of 1 millimeter. Right now, the boundaries in technology are being pushed so far that we are actually going below 1 millimeter margins now to try and restore the teeth and preserve tooth structure at the same time. The other thing also is that basically that is the same thing as well for zirconia. And what has been found over the years, Irene Saylor actually reported this in 2016, that they've been shown to have similar success rates over porcelain fused metal. And now, if you are in practice, look very lifelike, that you can feel safe to use them considering the success rates that are out there. Now, there's another paradigm shift changer, and that's the adhesive cements. So initially, as I had mentioned, your mechanicals, your cements, They were just micromechanical cements, and I didn't want to bring out any particular brands. But what basically used to happen is that if you look at your porcelain fused to metal crown on the inside, the cast metal background would have a very rough surface, and then the tooth structure itself would also have a rough surface. So you have this micro-mechanical bonding, pretty much like what amalgam does with tooth structure. And now the cements have been developed. They have now become more adhesive. They have more ways of being cured, and so they're providing a more chemical bond, pretty much like the introduction of glass ionomers and resin-modified glass ionomers when it comes to direct restoration. So now these newer materials, they can bond to every substrate. They can bond to enamel, they can bond to dentine, composite, ceramics, and metal alloys. And now, because they can bond better, we're talking biomimetics. We're talking about preserving tooth structure and getting something to adhere to the tooth surface. So no longer, but we're talking about having better adhesives that can make them stick so that we don't have to prepare so much tooth structure. So now our preparations are becoming less and less aggressive. So just a quick classification, they are often classified according to the adhesive scheme, whether they're a total edge, self-edge, or self-adhesive. I'm just going to make a disclaimer that I am not a representative of 3M, but for your clinical purposes, something like Rely X Automix would be a self-edge, self-adhesive. And then classification by polymerization, where you either have to decide if the cement is going to be one that is chemically cured, or that is light cured, or that is dual cured. The dual cures, I actually like or prefer them because, for example, if you're going to be cementing a fiber post within a canal, then you do not need to worry about light curing so much. And that way you also don't have to have a whole large collection of cements, although you cannot use a blanket approach towards your cements. The other thing, the disadvantage with them is that some of them undergo color change with time, so they compromise aesthetics. They're technique sensitive. You find that if it's overflowed into proximally and you cure it, it's a struggle to remove them. But they do bond better to dentine than enamel. So now you are expected to do extra things like selective etching. And they also provide a low pH like dentine. So you also get that their pH is quite low. It's similar to dentine. So that explains why they actually bond better to dentine. So the other thing that's a paradigm shift change is the evolution of bonding systems. We have moved from generation 1 up to generation 8. And to be quite frank, it's not so much the technology on the dental chair. It was more the commercial that was driving and trying to find more time, or trying to find, how should I put it? Trying to minimize the amount of time that the clinician has to spend. So they'll come and tell you, this one, you can cure it in 10 seconds and it will be done. Or you need only one application. You etch, you don't have to etch and then rinse. So this is what drove the development of these. And they were actually pioneered by the industry that pushes the composites or the direct restorative materials. And now, because of that, we also are able to do selective etching. And selective etching, what it essentially means, you have to separately etch the enamel on the margin that is going to bond to your restoration so that you don't have weakness of the bond between the margin and the restoration itself. The bond strengths become tremendously increased. And again, you don't have to be dependent on mechanical preparation. So once again, we are going back to the preparation principles and saying, yes, you can prep less than that. However, you also have to think about the concepts of bonding to enamel versus bonding to dentine. You have to think about wet dentine and how the tubular dentine, the tubules will collapse if the dentine is dry versus bonding to enamel. So I will not bore you with those sorry details. But the other things that have also improved how we do things is the surface enhancements of our crowns. So the crowns now, you can use silanizers, which have coupling agents, so they can create microporosities on the surfaces of those ceramics, especially the zirconias, which are very inert and difficult to bond. And also we can, we've been advised now, there are better tests that have shown that we can do ultrasonic cleaning, clean up the porcelain that we've etched to remove the acidity, which might be destructive to tooth structure, and debris, which might prevent the bonding. So our bond strengths are going so high that they actually, most of the time you will find that the bond between the porcelain and the actual cement is competitive with the bond to enamel, or the bond within the enamel structure itself, the cohesive forces within enamel. Here's the big buzz one as well that's been there for a while, which I actually no longer consider a disruptive technology anymore. It's an everyday use now. We can do digital wax up, we can do digital smile designs, and therefore we can actually accurately measure the parameters and determine how much to start with possible. And we can even go for veneers and inlays and onlays that are much thinner, that have been milled with precision. And as I had mentioned before, there are now newer composites as well, which have high density polymers, which can actually allow them to bond much stronger than your direct composite restorations that you use on the day-to-day. And now, when you used to know of occlusal veneers being milled up to 0.5 millimeters, they can even be milled, they can be milled between 0.3 and 0.6 millimeters and still be able to withstand the heavy occlusal forces. The problem with this outcome of these studies is that these are new studies, some of them are in vitro, and we still need long-term data. The jury is still out on that one. So for studies that were done by people like Schlichting et al. In 2011 and Fradiani, that was 2011, we are at 8 years, 9 years. So we would love to see the 10-year results on those restorations that were done using those technologies. So how have the preparation margins changed now? If you are doing monolithic lithium disilicate crowns, your typical EMAX crown, occlusal reduction would be 1.5 millimeters if you're not veneering, or you would do 0.8, and then another 0.7 when you consider veneering. And then if you look at it, the 0.8 millimeters that you've reduced, it actually gives you fracture resistance of about 400 MPas. But if you reduce the other 0.7, it's been shown that the porcelain, because it's very different from the lithium disilicate, it only gives you a fracture resistance of 100 megapascals. And that is because porcelain itself is such a fragile material, it fractures easily. And therefore, that 0.7 that you have veneered, it really does not make any significant difference to how the restoration is going to resist fracturing. So technically, why keep it there? And that's the argument that is based behind the newer preparation designs. Why do you need to veneer the porcelain if it is not going to add any difference? And especially for posterior restoration, 400 MPas of fracture resistance, then rather just do a full monolithic crown and put the margin at 0.81 millimeter and leave it there, and do not. So actually, you can go below 1 millimeter. For those of you who did your preclinical courses, you might have been told EMAX strictly 1.0 millimeters, but actually at this point, now we're pushing the boundaries. We're even trying to go down to 0.6 millimeters. So again, less tooth structure because we've got better bonding mechanisms, biomimetics, and it's been shown to be sufficient for posterior regions. But again, as I had said, I need to put a disclaimer. Some of these studies, we are waiting for 10-year outcomes to see for success. So this is basically the picture that I wanted to show you. Originally, when you did your occlusal tooth reduction, you would take away from 1.5 to 2 millimeters anteriorly and posteriorly. For example, if you're doing your full mouth rehab, and you'd also make sure that your axial reduction as well, you would try to take away about 1 millimeter all around. However, now they're pushing the boundaries, I have said. Instead of having occlusal reduction of only of 1.5 to 2 millimeters on your functional cusps versus your non-functional cusps, then now we can actually push it down to 0.8 to 1 millimeter. So this is where we are right now. I mean, look at how shallow that margin is. And I would think to myself that if you've taken an impression of that, it would probably be very difficult to see. But we are taking optical impressions now with CAD/CAM. So those can actually be clearly identifiable on your optical impression. Hence now the case that was done, this was actually a full mouth rehab that was done using very light chamfer preparations of 0.4 to 0.6 millimeters. And these restorations were fabricated after the milling, and now the restoration was like that. This was a full mouth rehab. So the demonstration around it was that we actually can consider doing full mouth rehabilitations without removing too much tooth structure, because patients who actually require this type of restorations, they already have lost so much tooth structure. So the additional benefits as well is that because we are milling, the zirconia can be polished, it can be glazed. However, polished zirconia will wear the opposing restorations or the teeth much better. And if you're looking at zirconia versus lithium disilicate versus feldspathic porcelain, it actually is the one that expresses less tooth wear of opposing dentition. In summary, I'll quote the words of Pascal Magnier in 2003, who said, it should not be just about aesthetics, but it should also be about conserving dentistry. And my favorite one was Divan in 1952 already, who was saying our goal should be the perpetual restoration of what is missing. And in that way, I would like to say thank you. I hope I didn't lose you in the process. Thank you.
Dr. Mmutlana, we thank you for your very informative and knowledgeable lecture. You had really some challenges tonight with your connectivity and so forth. I see it went a little bit better when your video feed was taken away. I just want to ask the viewers and our colleagues that had visited us tonight, if there's any questions, please, we've got a few minutes to answer some questions and answers in the Q&A box. So please, you're welcome to ask any questions. I see there is a few questions. If it's possible for Dr. Mmutlana to redo this lecture, because there's really some salient and very important facts that we use every day in a normal dentistry and in practice. So Dr. Mmutlana, yeah, we were almost 560 viewers tonight, so it was very, very good. Please, if there's any questions, we will answer that now. Dr. Mmutlana, the first question I've got for you is do you have a burr that you prefer for making your chamfer? Is there a specific burr?
Thank you very much for the question. Without really looking at a specific brand, one of the things that I have always preferred to use is that I completely stay away from flat-ended burrs when I'm prepping my margins. As I had mentioned, I do not prefer the chamfer. Currently, what I'm looking that I see now that I think it's Horico or Comet, they are now coming up with calibrated burrs. So the burrs actually can even measure the depth of how far your margin is. And based on that, I think I would love to try out. So yes, for me, I have either used Comet or I've used Horico, but I wouldn't really stick to a brand. I would just say my diamond burr that is round-ended, and I'm staying away completely from flat-ended burrs. Yeah. And of course, the chamfer burrs I would use if I'm going to prepare an ordinary chamfer, say for example, for a porcelain fused to metal or for a veneer. Okay, I don't know if I'm still audible.
Dr. Mmutlana, are you there? Can you hear me? 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 Can you
Yes, I'm still here. I just wanted to respond to the comment about redoing the lecture again. I would really gladly oblige. I do understand we faced some real challenges tonight, but we've been having power outages throughout the day today, so perhaps they've affected how everything is being played out. Even the internet connection has been very challenging from my side as well. So yes, I'm happy to redo this lecture again.
Dr. Mmutlana, then there's a question. What is the difference between the translucent composite block and multi-layering blocks, and which one do you prefer?
Okay. So there is no one blanket approach towards the type of restorative material, and that's one thing I would like to emphasize as well. So the composite blocks, those are the ones that I have spoken about, that I said they are your high strength composites. They've got polymers in them, and these polymers actually make them so strong that you can mill them in thin sections and do what they call occlusal veneers or overlays, a technique that is currently very popular with clinicians who practice full mouth rehabilitations. And then your multi-layered, as far as I know, the multi-layered zirconias, those are the ones that are actually much stronger, and you do not need to, how should I put it? You actually avoid veneering them with porcelain, as opposed to where you've got this one layer and then you want to also veneer it as well. So multi-layers, the good thing about them is strength, consistency, and also because of that, they are so compact that they can be milled in very thin sections. So the difference between them is that those ones are composite blocks with high strength polymers, and then these ones are your ceramics or your nano ceramics that actually are so compactly packed that you can actually mill them in thinner sections. So I prefer the multi-layered actually for posterior restorations. To be quite frank, I have never really used the composite blocks. It's something I look forward to doing when I do rehabs. The economy is quite tough at the moment, so not many people are showing up at our door and saying, I want a full mouth rehab, you know. But I would love to explore that.
Dr. Mmutlana, then there's lastly, there's one question from Justice Temba. In severe fluorosis cases with variable destructive lesions, what approach for full rehab in preps would you use without digital enhanced assistance?
The biggest challenge with the fluorosed enamel is that when you are talking about bonding to enamel and you're looking at the resin tags and the microporosities that are created within the hydroxyapatite crystals, this time you're dealing with fluorapatite crystals. So for me, the most important thing is about how to surface treat the fluorosed enamel. I have done a full mouth rehabilitation, and when we redo the case, I'll actually bring it up. I would have loved to follow up and see where the case is, but the two patients that I did, they actually relocated. So for the full mouth right up to the 6, I actually went for lithium disilicate. And I will tell you why. Most of the time, we say, let us use the strongest material, and even for patients who've got parafunction and so on. But I think if you've got a restorative material, and right now, actually, there's even, they don't call them flowable, but they call them injectable composites, that you can actually use a silicone mold that was made out of your wax up, and then you actually can inject. And I think one of them is a GC product called, I think it's called Genial, yes, that you can actually restore. So depending on the depth of the destruction, if you are going to be prepping away all the way into dentine, or you're going to be leaving some enamel behind, the real game changer for you will be how deep is your margin. I mean, how deep is your preparation? Have you prepped into dentine or have you prepped into enamel? And in that case, then how are you going to bond and how are you going to make sure that the margin is treated? So yes, once again, you look at issues like selective etching and various strengths of acidity for fluorapatite crystals.
Dr. Mmutlana, I will take a last question from Jonathan Miller. He asked, in hard-to-see areas such as deep subgingival distal margins, how do you control your depth of preparation?
So first of all, what guides me in terms of my preparation is I look at the radiographic. I take my radiographic assessment, and I prefer that if I'm going to be, I need to have periapicals, and now we also have our CBCTs, we can assess how far it goes. And if I can see that the margin is not going to be visible in the mouth, or how deep can I go, then it means it also limits the type of materials that I use. If I intend to be using the newer ceramics, then certainly, whether they're going to scan my impression or it's going to be an optical impression of the prep itself, the problem is going to be visibility. So rather, perhaps put a provisional restoration in place and then consider other adjunct procedures where you refer the patient to a periodontist for bone sounding and to examine whether you should explore crown lengthening. So if already radiographically I see that we are not going to win and it's sitting with a direct restoration or with caries, I already consider surgical intervention before I can actually even consider controlling the margin. The only way that I would consider it is if I'm subgingival at least by 0.5 millimeters, then I would go down that road. And then, of course, we would look at other techniques like when I take the impression, the cord packing, like your double cord packing technique.
Thank you for your answer, Dr. Mmutlana. Dr. Mmutlana, there's just one or two questions that we'll come back to the viewers and to the colleagues. The last question that we don't have to answer here is people want to give us images. One guy asked, anonymous guy asked, please can you give us images of the burrs you recommend in your re-recording, but that will answer via this SADA platform. Dr. Mmutlana, I think we finished for tonight from SADA Mpumalanga branch, and all our viewers, thank you very much for your very, very informative lecture. And I think it's an everyday important facts that you gave through today. You really had some challenging times tonight with the connectivity and so forth, but we'll work on that. And yeah, to all our viewers, please stay safe and look after yourself, and hope to see you on the other SADA webinars soon, on this Thursday, next week Tuesday, and so forth. So have a good night and have a good evening.
Thank you very much to SADA. It's been an honor to present on this platform, but as I said, I would like to really make it up to the audience that we redo this presentation again. And yes, I will definitely put more of the visuals with the burrs that I prefer at the next re-recording. Thank you.
Thank you very much.